fact that a lot of the healthcare force is a female force. They have been affected potentially in a different way, and gender equality is going to play a major role. We have a various panel that's going to discuss this topic, what it means from a socioeconomic aspect, from a patient perspective, from a policy perspective, and then from a healthcare provider perspective, as well as look at it, how it potentially is viewed differently across many geographies. So with that, I'd like to introduce the first speaker, Maria Holzberg. She's a humanitarian advisor and the COVID coordinator for the Asia and Pacific Regional Office of the UN Women. So Maria, I'd like to hand it over to you, and then we'll take questions.
Thank you so much, Barbara, and it's an honor to be here today. I'm here to be sharing some insights on what the impact of COVID-19 had on women or a woman's life and health. And I will be walking you through, and this is why we have some slides, I will be walking you through some of the insights that we as UN Women came to at the outset of the pandemic, and how this will be affecting us moving forward. Next slide, please. So just to say that we're in, there's been approximately 248 million confirmed cases of COVID-19, with about 5 million deaths, and reported by the World Health Organization. At the same time, 7 billion doses of vaccine have been administered. So that's where the global picture is now. But let's turn back a bit and see when the COVID-19 hit, what did it hit and what did it look like? Next slide, please. These are some of the elements that UN Women and partners have distilled through walking together with our partners and country offices in the pandemic. And what we could see very, very clearly was that across every sphere, so from the health to the economy to security and to social protection, the impacts of COVID were exacerbated for women and girls. So we witnessed increased discrimination against and violence against women. I will speak more about this. There were some recent experiences that revealed examples of stigma and marginalization that was linked to race and gender and leading to more inequality or inequity. We also saw a recorded rise in gender-based violence and protection risks. And we will talk about that a little bit further, but we do know that GBV is increasing exponentially. This is also the case in any disaster context. We also noted, and this came in the beginning, early days, that it is more challenging to meet the immediate needs of women healthcare workers, including first responders and care workers. We need to remember that women actually constitute 70% of the workers in the health and social sector globally, and they are on the front line of the response. And there's been many instances where women healthcare workers called for the need for improved equipment that was applicable for their context. The final piece, which I will share further on, is just to highlight for you, is the exacerbated burden of unpaid care work among women and girls. So when the healthcare system is stretched, women need to play a bigger role in taking care of those that are in the home. This also impacts the women's economic empowerment and livelihood. We also know that women are only a small minority of global health leadership, so they are not part of the decision making. Next slide, please. So I will in quick succession now walk you through some of the research that was done. And you and Women and Partners did a number of surveys. We rolled out surveys in target countries to really unpack some of the dimensions related to the pandemic. We know from this research, and this will be shared afterwards, that women have unique health needs, but they were least likely to have access to quality health services, the essential medicines and vaccines. We also know that the pandemic made it more difficult for women and girls to receive treatment and health services. Next slide, please. Here we're showing you now, and it's a terrible resolution on the PowerPoint, but it's basically an overview that we've done. We've surveyed 8 countries in the Asia Pacific region who've reported an increase in domestic violence cases during or immediately after the lockdown period. So many countries engaged in lockdown. When those measures were taken, violence increased. And we've seen this very strongly manifested online, where we see that search queries related to violence against women, including physical, sexual, and psychological violence, all rose during the period that we reviewed. So, for instance, searches related to physical violence grew in the Philippines by over 60%, 55% in Nepal, and 47% in Malaysia. We also saw an increase in online misogyny with instances of trolling or using images without consent or sexual harassment. The final piece on that is that the help-seeking searches also increased. So, for instance, in Malaysia, it increased by 70%. The next slide will look at the sexual reproductive health and mental and emotional health. So we did see a disruption in contraceptive services, which will have led to unintended pregnancies. We also have seen that the unintended pregnancies put a great strain on families that are already struggling under the pandemic related financial situations. Also, the mental and emotional health has also been something that we've been able to see in our measures. For instance, the increase in unpaid care work or domestic work, jobs, and income loss has really affected the heightened sense of stress among the populations. Next slide, please. So what we saw and what we're seeing now, because this is the effect that we're talking about right now, and we are using examples from Asia Pacific, but this is translated across the world, is we're looking at this as a profound economic crisis. So this is really affecting people's livelihood and participation in the labor market. We've seen that most of the people in Asia are working in informal employment, and this vulnerability was exacerbated by the lack of social protection. We saw, for instance, that 84% of women who lost their jobs did not work, do not receive unemployment benefits or other forms of government support. So this is really talking about increased marginalization and overlapping vulnerabilities. Next slide, please. And this is the final slide when it comes to what we've seen affecting. And I'd like to just draw attention to that all these findings, so the unpaid care work, effects on the health and the economic factors, this is applicable to one woman in many different countries. So we're trying to paint a picture for you of what the impact had on women, the impact the pandemic has had on women. Just to go back on the unpaid care work, we've seen an increase in unpaid care and domestic work. This has been across and affecting women the most. And let's move to the last two slides, please. So we've talked about what were the impacts and what have we seen affecting women and girls through the pandemic. We also want to share a little bit about what we've also seen in terms of the vaccine and vaccine rollout. We've convened a listening session with women focus groups to hear their concerns. It's impossible for you to read the slide, but it really talks about how the intersection of the different vulnerability, the physical access, gender norms, and information have really served as barriers for women to actually access the vaccine, which are the steps to take to recover from the pandemic. Silence, please. Silence. Last slide, please. So through this listening session with women focus groups, we looked at what were the supply aspects and what were the demand aspects that impacted the access to vaccine rollout. And you can see here that there's still the marginalization, physical accessibility, this invisible discrimination. And one of the points that really came out so strongly is that it's the duty of the government to acquire vaccines for all. It's a right, it's not a privilege. And you need to find the measures to ensure that health is for all. I leave you there with these points, and thank you so much for the time.
Okay, thank you, Maria. Maybe before we go to the next speaker, I guess your talk nicely illustrates, right, that the vulnerable in a time of crisis and pandemic got even more vulnerable. But I thought what was extremely intriguing is your last summary on the situation of the vaccination. So what are your key learnings, or what will be your call to action in terms of, because the vaccinations topic is still real, right? And we see that across, and I think you have highlighted it now from a different angle.
Thank you for that question. And what we would really want to put forward, and I don't want to say it as UN Women, but as gender actors, is to make sure that the rollout that governments do really looks at the barriers that women face in terms of accessing. If you're not seeing enough women standing in the vaccine line, you are not reaching the full group. We have examples from Nepal where mobile vaccinations have been conducted. So this would approach women who have limited mobility. There's many examples across the world of where vaccines have reached. It's very important when you talk about rollouts that you really listen to those that are living in the reality where you want to change. Thank you.
Thank you, Maria. No, final question, then we move on, but we are good with time. And do you believe that this type of lens is already being used, or it is still, the awareness is so low that actually still much more work needs to be done in that area?
I think it's an answer that has, it's a question that has many answers to it. We know that men in many contexts access vaccines more than women do. We see these examples from Pacific, for instance. So from that perspective, even if you're developing a vaccine rollout plan using a gender lens, you're still not reaching women. Having said that, we have examples where you have been able to target specific target groups such as teachers or healthcare workers, where women are part of that. And when women are part of the conversation, you will usually be able to get more people to get vaccinated. So we see this as, I would say, it's I would say yes and no, because it's an intersection of different issues. Thank you.
Thank you. Thank you very much. We'll come back to that. There are also some questions in the chat, but we'll address them at the end. I'd like to move on to the next speaker, Isabella Della Mata, Principal Advisor of the Health and Crisis Management at DG Sante from the European Commission, and she will give more of a policy perspective. So Isabella, the floor is yours, and thank you for being a speaker today with us.
Thank you very much, and it's a pleasure to be here in this meeting with all of you. I'm going to begin in the opposite direction that I had intended before listening to the first speaker. And I want to begin with something that I just read this morning in a newspaper that says, without data, there is no visibility, and without visibility, there is no priority. And I think that this put the example of the situation where we are right now. And it's also regarding the pandemics. Everybody has been very busy fighting the pandemic, and sometimes collecting the data about the vaccination, the sick people, the deaths, and etc. And making the data disaggregated has been seen as a burden and not as a must. And because if we want to understand what is happening and to move in the right direction, we need to know what is happening and understand why that is happening. And we know that the sex, the gender, and the age are the variables that are essential to know the dimension of the pandemic, the numbers of the pandemic. And we know that there are differences by sex because of immunological reasons, because of biological reasons that could explain. But there are also reasons that explain the difference because of the age. There are more women in the elderly age, and the elderly have been more affected. So at the end, there will be more women that have been affected by the pandemic, even if the men have been the ones that are dying or that are most dying because of the biological factors. And we know also that the chronic diseases have been an explanation of the different numbers. And there are also even if the life expectancy is higher in women than men, we know that the healthy life years are not the same, are not reflecting the same numbers, because women live more, but in worse condition at the end of the year. And we know also that the women are the ones that are taking care of the family, and that the women are more in the care professions, so more healthcare professionals, more care professionals, so they have been more affected than men by the pandemic. But at the end, that if we want to make the policies that are effective and efficient, we need to know the statistics. We need to know the indicators disaggregated, that we could understand what is happening, and what and why there is a gender inequality. The inequalities, or fighting inequalities, have been forever in the EU policies, and is part of the Treaty of Functioning of the European Union in one of the first articles. And so Union of Equality was also one of the priorities of the new Commission and of the President of the Commission, Ursula von der Leyen, by the way, the first women as President of the Commission. So gender equality is a founding principle of the European Union, and we have designated a EU Gender Equality Strategy 2020-2025, where, of course, the main objective is tackling gender discrimination, but there are also the vision, the policy objective, the actions to make progress on gender equality in Europe. Health is mentioned in that strategy. We talk about good practice exchange between the member states and the stakeholders in several areas. Of course, as one of the main points of in the EU for Health is the EU Beating Cancer Plan. We have also put examples in that area of how we come to fight this inequality and war. But something that is new is that for the first time we are going to gender budgeting, or at least to try to measure how we are gender budgeting. Because I mean, at the end, is the way that could prove that we are doing something. This is new. We are still in the learning phase, learning methods. So the gender equality tracking methodology is under review and will be implemented not later than the 1st of January 2023. You can say that is a long time. The study is 2020, but we are implementing in 2023. But it's also true that we are learning, and we didn't know really how to do. We were talking forever of gender mainstreaming, and we have been trying to do that, but then we were not measuring. And as I said, that measuring is essential. We are trying to do that. So we are going to apply a scoring principle, assessing the different projects according to the direct and indirect impact. We are what we intend is to have results and indication on how much of the expenditures count as gender equality relevant. And also I want to mention that the EIGE, the European Institute of Gender Equality, that is providing a report of how the member states are behaving regarding gender equality. The report this year has concentrated in health. And in health, of course, different areas, but COVID-19 has also been one of the main areas. What we have seen is, well, not only mortality, morbidity that I had already mentioned, but also how the citizens, the European Union, have been affected not by COVID. I mean, not of COVID, but by COVID. So all the chronic patients, and 21% of the respondents have missed a medical examination or a treatment during the pandemic. And 18% have been experiencing a health issue that could not be treated because primary health care in some areas, in some countries, was closed down for most of the first month. Treatment for chronic patients has been delayed. Even non-urgent operations have been delayed. And well, how the women have been disproportionately exposed to the infection because of being frontline workers and etc. Then the impact of mental health has been very important, and women have been also more affected than men in that area. The gender-based violence has been increased, and especially the intimate partner violence. And we have made studies on the confidence on the vaccination. And contrary to what has been usual for what we call the regular vaccination, and in the confidence report that we have been launching in 2016, 18, 20, now we prepare in the 2021. Usually women are more confident in vaccination, and also older ages more confident in vaccination. For the COVID-19, the situation has changed a little bit. They are more similar, women and men, confidence in the COVID-19 vaccination, but a little bit more the men than the women, so has changed. However, the numbers, effective number who has been vaccinated, we don't have that disaggregated by sex, and we will need to have that. So it's something, a lot of work that we still need to do. That takes time. We know that people are very busy fighting the pandemic, but I want to insist that information is the only way to move on policy and on health policy. If we don't have the data, we don't have the information, we cannot proceed. And getting the right information is not separated from getting the right health care. And it's just an essential part. Health information is an essential part of the health system. And we need to go with that and to be able to collect everything that will allow us to move and provide a better health for our population. Thank you very much.
Thank you, Isabel. One question again before we move ahead. You said how important it was to have the data in order to raise the visibility. I thought your opening was extremely powerful because it's a simple message, but it's very true, right? If it's not visible, it's never going to get a priority. And as you're explaining how this tracking system is being put in place, what do you believe will be the biggest benefit in terms of, apart from having the data and raising the visibility? Do you believe that specific topics will surface? Will it also create peer pressure amongst member states? How do you personally judge what will be the other effects apart from having the data to discuss?
I mean, having the data just for having the data makes no sense. And we need to have the data to be able to act. I mean, when we have the data of mortality disaggregated by gender, or the data of morbidity disaggregated by gender, that has allowed us to understand a little bit more of the pathology of the disease. So how, what, who was being affected and why. So I said that there is a biological factor on men dying more, but it was also because they are more affected by respiratory diseases, for example, and that was important. By lifestyle, we have seen that obesity has also been a factor for going to the intensive care units, and there were more elderly or certain age women that were obese, so they were more there. So we need another thing that could surface if we understand who is vaccinated more. We could tackle and address a specific policy to increase more the vaccination in women. Why women are less confident in COVID-19 when they are more confident in measles or in flu? We don't know yet the solution. We hope we will have a response for that on April in the next report. That will be, I mean, a little bit late already. But no, never late. I mean, we could move with the next with the next rounds of vaccine and etc. So, I mean, if we don't measure, we don't know. If we don't know, we cannot act. So it's really important. The fact that women were less affected because of biological reason, but more affected because they are in the front line professions. This is also that came from the data, from collecting the information. They are more nurses, more doctors, more home helps, more, I mean, all the caring professions, more teachers also that have been, especially in the primary education, so that they have been more exposed when that the school was reinitiated and etc. So not information, not data just by data to be able to respond, and so this is the important thing.
Thank you very much. And I'm sure there will be questions at the end of the panel. So I'd like to introduce the next speaker, Naya, who will give us a patient perspective. Naya leads the European Hemophilia Consortium think tank. And I'd like to hand over to you, Naya. I'm sure you will shed a different light on some of the aspects that have already been discussed.
Excellent. Thank you very much for this kind invitation to bring in a patient perspective. My name is Naya Rasmussen, and I'm definitely working at the European Hemophilia Consortium think tank, where we try to encourage a systems change and how we collaborate and how we solve complex challenges in our healthcare system. But I was also a part of founding the European Haemophilia Consortium's Women and Girls and Bleeding Disorder Committee back in 2018. We actually started a little bit earlier than that, but we got officially founded in 2018. And what I would like to do in this short presentation is to give you a little bit of insight on what does it mean to have a bleeding disorder as a woman, but also how how we have felt impacted by the COVID-19 pandemic. Because I'm not quite sure everyone knows exactly what a bleeding disorder is or how it can affect women. But let me start with just this very sad fact, basically, is that women with bleeding disorder has been underserved and just marginalized completely in the bleeding disorder community for many, many years. Hemophilia is kind of a known disorder. It's a rare disorder, but it's still quite known from a lot of people. But what people forget is that it can actually also affect women and not just men. It can affect them differently, but they can also be infected very similar to men that I will come back to later. But apart from that, there's also quite a lot of other bleeding disorders, which, for example, the one I have is called von Willebrand bleeding disorder. It hits equally men and women. And beyond that, there's other factor deficiency, as we call them, and platelet disorders. And the common thing about this is that your blood have difficulties clotting. So it can happen if you get a spontaneous bleed, you will bleed for longer time. If you need to go into surgery, you'll bleed for a longer time. And in particular, when you're a woman and you have your period, or you need to give, you're pregnant and you need to go into delivery, it's a larger risk of you having extensive bleeding, and something that for a lot of us needs to be controlled medically, because otherwise we're not necessarily going to make it out of it alive. So to give you a little bit more into the life of a woman with a bleeding disorder is that, yes, you can have bleeds similar to men. You can have joint bleeds, you can have extensive nose bleeds, you'll have a lot of bruising. And when you're a kid, you might bomb your head, you get really big bruises, needs to be controlled. Some needs a regular treatment, some only need treatment on demand, and some need just extra attention. And if case it's really severe, you need to go into an operation, then you need to have a treatment plan in place. But for a woman, there is these extra elements of you have the opportunity to produce children. You can become pregnant, you have your period, and all these things, because you have your uterus, there is just an extra layer of concern and an extra layer of responsibility in terms of what your body can do and not do. And for some women, you might need help with fertility treatment. I had a period where it was way too extensive. I was bleeding way too much. So from an early age, I need to have medication to control my bleed. And a classic way of treating that is to use hormone treatment. But if you want to become pregnant, you can't no longer do the hormone treatment, obviously, because that is to control your bleeding and control that you don't become pregnant, as well as controlling your period. So you need to step out and you need to have a lot of counseling and to figure out how you're going to control your treatment when you also might have a lot of bleeding that needs to be controlled at the same time. On top of that, you also need to take into consideration that this is a genetic disorder. So your offspring might get it too. And how are you going to cope with that? Is that a risk you want to take? Or do you need to go into fertility treatment to figure out if you need to do a selection of it? And is that even legal in your own country? And can you even do that? So there's a lot of extra things, a lot of genetic counsel you need to put on top, that your own body will react in certain ways. And you need to put that together and figure out with your partner about how to go ahead with this. So some of us might need fertility treatment, some of us might not, because we might conceive naturally and it all goes very well. But we all need genetic counseling to understand what is going to happen. And on top of that, we need a treatment plan. How are we going to cope in the pregnancy? How are we going to cope and not ending up in a postpartum hemorrhage that will be so extensive that we will need a lot of blood to cope with afterwards, or bleed for 3 to 4 or 5 months after giving birth, by also having to take care of a small child in this new world. One of the things that I've been doing as a woman with a bleeding disorder is that I, of course, been advocating for how can we ensure that we get a better life. And one of the things that we've done that was published this year is that we have defined some European principles of care. that also highlights the importance of support throughout your lifetime as a woman, but also emphasize that you're not alone in this, and you probably will need to have a more family-centered approach where you, as if you're a young girl, have a heavy menstruational bleed, that your family can help support you and figure out how you're going to cope with that. And when we take on the glasses, this is the second part of my presentation, and say, okay, so there's a COVID, there's a pandemic, there's a huge stress on a healthcare system. You as a patient are not necessarily going to be allowed to bring anyone in to the healthcare services that you need. So if you need to go to a gender council, are you allowed even to bring your partner or not? When you go in as a parent with your child having a bleeding disorder, and you need to figure out how we're going to cope with this young girl who's 10 years old, she's bleeding down her legs every time she gets a period, she bleeds for 3 weeks at a time, she ends up having a blood transfusion because then nobody can control it. If not both parents are in the room to help support and understand what's happening here, you're not necessarily going to get that whole approach, and the whole family can help support and make sure that this young girl actually have a better experience of how it is to enter your adult life with a period you have to have for maybe the next 40, 50 years. So that's one of the things that COVID have definitely had an impact on, is that you become very much isolated as a patient when you go and enter healthcare services. Obviously you can cope, but it's not a fun situation to be in at all. Another part is that as a woman with a bleeding disorder, you have your disorder, but you might also have an offspring who will have the disorder. And there was a German study made earlier this year, which actually highlighted that a lot of caregivers are lots more worried about COVID, how that the family can cope with it, and how you can cope if you get sick, or how you should cope if your child gets sick. All these caregivers are not women, but a lot of them are. And there is a tendency along a lot of the women I have met over the years, is that if you also have the responsibility as being a caregiver, it's not going to be your own personal health that'll be first priority, it will be your kids. So a lot of these women will miss their appointments, they will not necessarily take good care of themselves, so they actually will potentially, if they have a heavy menstruation bleed that is still not under control yet, or they're going into menopause and the body reacts in certain ways, they might get anemic again, but they won't necessarily take the time to go and see a doctor because it's not first priority for them. It always is the family that becomes first for them. And that's a huge issue, because we also see a lot of the female advocates being extremely stressed of being a caregiver, a female advocate, full-time working, and they actually are difficult coping with the stress of it, because you all have experienced the situation of isolation and not being able to prioritize your own health. So with that, I just want to finish, so there is a little bit of time for any questions that might have popped up, is that we have a group of women with a bleeding disorder who has historically been under-marginalized, or they have been marginalized. There's been a lack of recognition around that women can even have a bleeding disorder, and there's issues with that. And there's a lot of underdiagnosing. There's a lot of women that we haven't identified yet. And with the healthcare system under stress, a healthcare system that has now probably been more stressed again with a fourth wave coming in. But as also what we saw in this fall, when the opening of a healthcare system again occurred, was that women would not be first priority. They weren't first priority before, they're not going to be first priority again. So this is a really tough agenda to fight, because we see again that the men will be the first priority when we called into new consultation and so forth. So I really hope that when we have the new European principles that was published this year, and also just a setting like this can help create the awareness around that when we have a saying of that we need to build back stronger, then we really need to build back where women are not marginalized, but where we are equal in a system, in a healthcare system, where we have been struggling for so long just to get our voices heard, because the healthcare system might not even be designed for us to be a part of. So with that, I just want to say thank you. And I look forward to any further questions and a discussion later on.
Thank you, Naya. Maybe one question, and then again we can discuss at the end. From your perspective, and like with the discussions you had with various patients and the from or advocates that are advocating the same topic, and I think similar things that Maria or Isabel have raised, you're raising from a different perspective. What do you believe, what type of policies could be helpful if a next pandemic comes up or a next crisis? I guess it's not only because it's a pandemic, it's just because there is a crisis and then there is a brutal triage that happens, and that just works in a certain way.
I think policy-wise, there is what we can see is that, for example, in our space, it's always been defined as a hemophilia treatment center, but a lot of women do not have hemophilia. And if you go into treatment centers and you see, they will always know where the painkillers are. They will always know where the treatment products are for bleeding disorders, but they might necessarily know where any hygiene pads are, anything that can help you as a woman if you have a heavy menstrual bleed. So I think what COVID could also be a part of is that it shows the cracks in our system, and it shows us that now there is a crack. So now we really should think about the opportunity and take this opportunity to redesign and think from the beginning. Are we actually serving our entire population in our specific small group of patient groups, but also in the broader sense? When we do design our policies, do we have in mind the entire cohort of the people that we are serving or not? And I don't feel and I don't experience that we have had that so far. And I think that's the opportunity that we have. Then we can really look at stuff and use this reflective time and this crack in our system to redesign it and think about the full cohort.
Clear. Thank you very much. And I think it's actually a great lead into the next speaker, Dr. Irene Hösli from the University Hospital in Basel, that will give a perspective from a healthcare provider. And Irene, I'm sure that some of the elements that Naya has just illustrated, you have seen with your own patients, because I have seen you were affirmatory nodding during the talk. So very curious now to have you as our last panel speaker and then open it up for the broader panel discussion. Thank you, Irene.
Yeah, thank you, Barbara, and thank you to all the speakers. It was very interesting to have these different perspectives, and I hope maybe I can touch some of these aspects as well in my point of view from a really clinician side. Thank you for the invitation from WIFO. I will start with this cartoon from a female cartoonist drawn April last year. Just 1 month after WHO proclaimed COVID-19 as a pandemic. And I like this picture very much because I think it was frightening in the beginning, and we didn't know how to cope with it. But on the other hand, I think something is missing. So I think when we discuss about COVID, we at the beginning forgot to talk about the pregnant women because they were the young women, and we had the idea, so they are not at risk. It's more the men than the women and more the obese one. But more and more it came out that that was not the case. So I have just 3 topics, and I'm just going very quickly. I hope not to be too medical with my words. Otherwise, I think you can, I will explain. The first is the COVID infection increased directly maternal and neonatal morbidity and mortality. And this has been shown by data, by good data. Now we have systematic reviews coming up from mostly high-income countries, a lot from Europe, but then from the States, and low-income country less. But we can say in the moment there are typical specific disease in pregnancy, like preeclampsia, which means a high blood pressure, and urine in proteinuria. We have seen that these sick women, they had more often C-section, they were admitted to intensive care unit, and they died, only few, but compared to non-pregnant COVID-infected women, about 2 times higher due to complications after pneumonia. The same was could be shown for the fetus or for the newborn, because it was mostly in the third trimester. They had to perform the preterm birth, in most cases medical indicated. These preterms were more admitted to the intensive care on the neonatal intensive care unit. And just recently, there was data showing that there is a higher risk of stillbirth once a woman gets infected. And you see just on the right side, these are two pictures from our hospital of a patient, where you see inside the placenta, and you see the problem in the placenta, that the vascular can be closed by clots, by thrombotics, and on the other side, that you can find the COVID virus within the placenta. So I think that is the first that we have seen and learned. But on the other side, we know that the pandemic increased the maternal mortality indirectly. And I heard a lot of things already from the beginning from the other speakers, that we see in general the inequality of women. So what does it mean? I think there was a very good publication in The Lancet just recently that we see maternal death, especially in low and middle income countries. They occurred more frequently, sometimes because no antenatal care was possible, or not the pregnancy was detected, and then they suffered from a rupture ectopic pregnancy, but also after delivery might, through isolation, a higher risk for maternal depression, the stillbirth as well, maybe less antenatal care. And what was one benefit, you can say, in the high income countries, they have seen less preterm birth, maybe due to less stress, more home office, or less contact to other people. So altogether, these indirect causes, I think, might be due to the inefficient treatment of the healthcare system. So the last point is a patient blood management. What is the role of patient blood management? So for that, maybe I just to give you a short explanation, what is patient blood management? This is something where you say, in situations where you need a surgery, where you might need blood transfusion, how can you improve the outcome of the patient by reducing the blood transfusion and combining medical and surgical concepts, and that in a time frame. And this has been done in several parts, specifics of anesthesiology, traumatology, orthopedics, so on. And there are very good data showing significant result in a reduction of perioperative blood loss, reduction of blood transfusion, reduction of morbidity and mortality, and lower cost by lower hospital stay. So that means it's just something that you do not have to start at the moment of the operation, but you have to predict what can be a problem and to start quite early. So this system might be as well get a crack when there is the resources and funding are limited. And what we still know that in obstetrics, this patient blood management, I would say the awareness could be better. And that why? Because bleeding, mostly postpartum, but as well antepartum, is still the leading cause of maternal death worldwide, specifically in low-income countries. Now, these three pillars, what we call the first in pregnancy to start early to detect anemic women, or maybe not only anemic women, but women with low iron. And you can just see the world map about iron deficiency and anemia, which is, I would say, not quite, it's quite different in all over the world. And it might not be only the anemia by iron, but it might be anemia by other vitamins or anemia by infection, and to treat this properly and early enough so that in the second pillar, that means intrapartum, that you already start in a good situation with a good storage of iron, and you use additional methods to reduce the bleeding during birth and postpartum. And at the end, that is postpartum, to have a look of the volume supply and the vascularization, and maybe avoid unnecessary blood transfusion. So if now you could imagine and you could calculate how could be the impact of the COVID-19 on additional maternal death, I think there was a very good publication where they did a scenario just looking what would happen if the coverage of essential maternal and child health interventions were reduced. Very, very simple interventions, as you can see, administration of medication to stop the bleeding after delivery, just iron or vitamins, or if you have to remove the placenta after delivery, or even blood transfusion, and other like given antibiotics to treat sepsis, or women with epilepsy, and just have a clean birth environment, or treat women with a high blood pressure and eclampsia. And they have different scenarios. So one was a very simple one, a reduction by 10%, and the most severe was up to 50%. And if I just take the simple scenario, so you have a reduction of interventions by about 10%, that would mean you have 40% less of these patient blood management, and I would say 40% missed opportunities. And if you would calculate on death, that would go to 24,000 additional deaths, not by COVID, just by the indirect cause of COVID. And if you would take the more severe scenario, so you will get up to 100,000 additional maternal deaths. So at the end, I think this is one publication where we as well explained that a lot of women, they do not have risk factors, so that we have to prepare for every woman when she comes to deliver and when she comes to the antenatal care. So I would end with some ideas what could be future strategies in COVID or in other pandemic situations. I think the medical part, you see, these are very cheap medication, or very simple one. They are not very difficult, the access to get. And you see on the right side just a picture. I had the chance to be in Somaliland 2 weeks ago, and I was looking if they have this medication, and they sometimes, beside of the personal protective equipment, which was less lacking, they had sometimes the problem just to get these simple medication to treat women as a prevention. And the strategies, I think, for the politicians, I would say, it's very important to have a look for the strong support of the maternal child health institutes. And I just had a picture of there. It was running 100 deliveries a month in Hargeisa. I would say it's very clean, and they're doing, just the midwives are doing that. And as well, they had problems to get in the beginning all the materials and the medication. And with that, I think I will stop, and I'm open as well to questions, hopefully give answers. Thank you.
Thank you very much, Irene. Maybe I start off with the question. Do you believe that the importance of patient blood management is now even more understood, driven by the pandemic, and that there will be a more systematic approach to it as a follow-up to that, so that the awareness has risen?
I hope so, yes, because in the beginning there was the discussion about the blood products, about safety, about testing, and there was in the beginning a reduction of blood loss, specifically in low-income countries, and as well to be hesitant to use blood products where you do not know if there might be a higher risk of getting infected, even by a virus. So I think that should be a huge discussion and give more ideas how we can implement this patient blood management. Yes, I do.
Okay, good. So there was a question from the audience to you, Isabel, related to patient blood management, whether there is a EU directive and whether you believe that this will be further included. Let me just, I don't know whether you saw it.
Yep, I saw the question.
Right.
I saw the question, thank you. And as you know, the directive and the work that the Commission does on blood, tissues and cells and organs is about safety and quality. The management of the health system, the management of the patient, the management of how these products are used is for the member states. So in principle, no. But we are not revising the directive. We are thinking on revising the directive still. So there is a long way, and we will see. But take into account that the main objectives for the substance of human origin is quality and safety. Thank you.
Thank you very much. I'm just kind of scrolling through the questions, and please to all the panelists, just jump in. One question was, what can men contribute to raising gender equality? Anyone who would like to make a comment?
I can go ahead, give a shot, and I can give it to Maria afterwards.
Yeah, and I saw Maria raise her hand. Go ahead, Naya.
I think the men plays an important role. One thing is that the men are open to listen to what women say, what women experience, and take that seriously. There's also an element to ensure that when you design any policy, when you define any treatment guidelines, when you think about how you want to do things, you ensure that you have people at the table who knows what they're talking about. So you obviously need to invite the relevant people at the table, and in many cases that is also invite the female patients. In this scenario that I'm usually working in, then the female patient not necessarily invited to the table to discuss how should we organize a treatment center that makes sense for you to come to as well. So I think there's a huge role in listening, inviting in, and be open to how can we solve things together instead of battling each other about feel like whose voices are heard the most. Maria, do you want to put in?
Maria.
Yeah, thank you very much. I think, again, one thing that was just now mentioned is bringing women and men to the table, and that's obviously important. I was also thinking about touching more on this issue of unpaid care work and really looking at and scrutinizing, so we can, on an individual level, look at our household and see where the care work is being placed and how it's being addressed. Men are very, very much the solution, part of the solution, because men are very often the gatekeeper, maybe through unconscious bias, or through conscious bias. So having a open dialogue about the benefits of a gender equal society is for all is essential, and we need strong men to share these perspectives and create the measures needed to bring more women to the table. Thank you.
Thank you. We have 2 minutes left, so before maybe I make a couple of closing remarks, is there anything from any of the panelists where you would like to make a comment, or any thoughts that maybe another speaker has triggered and that you'd like to bring up? No? Okay, good. So feel free also to add to my closing remarks. I think if we look back, very interesting hour and extremely different perspectives, but most important, very engaged panelists, and all of you feel passionate about what you do. What I guess we go back to Maria. Maria, your point was very clear that it doesn't matter what type of crisis, whether it's the pandemic, the vulnerable are just becoming more vulnerable. And you opened nicely the whole session to say gender equality matters not now, it's going to matter for a long time, and any upcoming crisis is just going to magnify some of the problems. I remember your last chart that displayed a lot of data. And then the lead over into the vaccination that nicely had Isabel open up. There is no, if we don't have data, there is no visibility. And if there is no visibility, there is no priority. And I think Isabel, you clearly said if policy needs to be defined, we need to have that data to support that. And then Naya, I think it's very clear. Right, there are still certain bleeding disorders that are being neglected or underestimated. 20% of women at reproductive age actually have heavy menstrual bleeding, and we know from our own experience working in iron deficiency that this is likely to be underreported and underdiscussed. And Dr. Hösli, I think you nicely highlighted the patient blood management, but also like maternal death during the pandemic. But we also know that maternal death is twice as high if you basically do suffer from anemia. And hopefully what this panel has done and is going to do moving forward, and I go back to how Isabel opened, is raise visibility from different aspects, multiple voices heard, some questions raised, but raising the visibility that really supporting to make these as a priority. And I'm sure that in a year from now, we are going to have similar conversations, or we might be one step further, but definitely there will be more data to look at and to have the facts in order to support policy making. So a really, really big thank you on behalf of myself, but also B4 Pharma. I was truly impressed. It gives a meaning of what we do every day, but also gives me a meaning as just a female leader. I will try to do my best and contribute as much as I can, raising that visibility. So thank you very much.
Thank you.